Welcome, everyone. Five Wishes is pleased to present today's webinar, Virtual Advanced Care Planning Conversations, Creating Meaningful Connections Across Distance. My name is Jennifer, and it's my pleasure to facilitate. We are recording the call, and we muted all participant lines. If you need help, please email fivewishes@compartners.com or send us a message in the chat box. If you're listening over the phone and you need help, please press *0. The presentation will last up to 60 minutes, and you're encouraged to ask questions throughout. Please submit a question by typing it into the chat box in the lower left corner of the screen, and be sure to click the Send button. Do also take a look at the links box located above the chat area on the left. Here are resources you can view, save, or print. Simply click on the link of your choice, and a separate window will open. This will not interfere with your viewing of the program. It's now my pleasure to introduce Paul Malley. Paul is the president of Aging with Dignity, a position he's held for 18 years. With more than 20 years of experience in the field of aging and advanced care planning, Paul is a national expert, frequent speaker, and advocate for quality and dignified care at the end of life. Welcome, Paul. I'll turn it over to you.
Thank you very much, Jennifer, and welcome to everyone. It is so good to have our Five Wishes practice community gathered together again. So much has happened since our last webinar in February. In some ways, it was just a bit ago, and in some ways, so long ago. First, a sincere thank you for all that you've done and the challenges you've overcome these past 2 to 3 months. Whether you're anchored in clinical care, administration, management, education, outreach, if you're working in healthcare, you've likely adapted to a significant amount of change in the past few weeks, all while doing your absolute best to take care of the people around you, either your patients or members of your team, or in many cases, both. We see you. We hear you. We're grateful for your comments back to us at Five Wishes, and we want to keep hearing from you. We have several hundred of you joining us today from, I think, all 50 states represented, a few internationally as well. Our common bond, what defines our community, is the desire of healthcare professionals to know the people you're serving, to really know them, and to align their care with their preferences. We understand that many of you who use Five Wishes do so because it focuses on the person, not only the medical or the legal issues. But Five Wishes starts by understanding who the person is, what's important to them, and affirming their worth. If you've seen the updated version of Five Wishes, which went into circulation just earlier this year, you may have already noticed a few improvements that are in line with this goal. The first is that wish number 3 has been better aligned with a focus on comfort, particularly physical comfort. It now focuses more clearly on what gives a person physical comfort, which is so often a concern for people as they consider or experience illness. Wish number 4, my wish for how I want people to treat me, now focuses more clearly on personal, psychosocial, and spiritual support. These are often the things that help bring a person a sense of dignity. And it also includes now even a bullet point, a prompt that says, I wish to be called by name. Please call me, and then it has a blank. And they can let you know whether they want to be called by their first name, or Mr. So-and-so, or Miss So-and-so. It sounds simple, but it means so much, and it's so personal because it deals with their name. Wish 5 now even has a deeper interpersonal connection with healthcare providers. We added language asking what's most important for healthcare providers to know about you as a person, where the patient can write that in the blank lines. And Five Wishes now meets the legal requirements for an advance directive in 44 states. That's up from 42, and it's usable everywhere. So we added Utah and Alabama to the list of Five Wishes states where it meets the legal requirements, and it can be used across the country. We made these improvements to Five Wishes based on the feedback from people who use it every day, including patients and their loved ones, and you, our healthcare partners and community. So thank you, really thank you. Your input and ideas also helped us to create a really useful and comprehensive program of tools and resources for healthcare providers over these last few years that are all new components. So today's topic, a timely topic, focused on virtual advanced care planning conversations, is also based on your input and your request. We heard from the Five Wishes practice community that you wanted to know more about how Five Wishes and advanced care planning can be done, and not just done, but done well via virtual connection and still keeping a focus on the person. Kathleen Taylor is our Five Wishes healthcare advisor, and she's going to tell you just a little bit more about the practice community and how we ask for and receive your input. Kathleen's been working in healthcare for over 30 years. She has a passion to improve the healthcare experience for people who are sick and vulnerable, and to help healthcare professionals find joy in practice through cultivating empathy and communicating compassionately. So with that, I will turn it over to Kathleen Taylor.
Thank you, Paul. If I have the next slide, please. Thanks, Paul, for that introduction, and thank you again to everyone for joining and for keeping the fire lit with everything that you're doing to serve patients and families right now. And can we have the next slide, please? Oh, there you go. I want to just briefly review, well, back to the other slide. It took a little delay before I saw the slide change. There we go. I want to briefly review what the Five Wishes practice community is and why we're bringing you offerings like this webinar today. As you can see on this slide, the Five Wishes practice community is a collaborative community of healthcare professionals who are using the Five Wishes program for your advanced care planning. And you are in it right now. The goal of the community is to enhance your practice. And we do that through sharing best practice stories, and you're going to hear a lot of those today, sharing resources with each other, information, and a lot more, tips and mentoring as well. And it doesn't cost anything. If you are using any Five Wishes program component, like the Advanced Directive document, our Five Wishes online training, the conversation guides for clinicians or the conversation guides for individuals and families, if you're using any of the components, this is our way of helping to ensure your success. We want you to use the program, but we also want to help ensure that you're having the best conversations possible as you do use the program. We want to get your input so that we can keep developing tools and resources that are meaningful and useful to you as your needs change. And some of the ways that we get your input through the practice community, we send out surveys occasionally. We did a big push on this last year, and many of you responded. We will likely do another one in the next few months, and we would love it if you would take the time to answer some questions and let us know what you need. We get your input through webinars like this. There is, as Jennifer mentioned, a chat box. You can ask your questions and make comments there. Even if it's not related to today's presentation, we can get back with you later. We'll have a record of everything that anybody types in that chat box. And you can also reach out to us anytime. One thing I want to remind you to do is during your regular ordering process, when you are picking up and ordering new Five Wishes program components, tell us how you're using the components and how they're working for you and what else might be helpful. We would love for that to just be a regular part of your relationship with us. We know that sometimes it's the purchasing person that we're interacting with when people are making new orders, but we really hope that we can also hear from the clinicians who are using the tools so that we can find out what's working in the field and what else you'd like. Can I have the next slide, please? Over the last couple of months, what we've heard from you is that it would be helpful to focus on remote advanced care planning conversation skills, how to have sensitive and skillful conversations using virtual tools, and to feel confident doing it. I think that's a huge part of it. Healthcare providers know how to make rapid adjustments as the situation demands. That's what we do. And with the coronavirus pandemic, there has been a rapid shift to more clinicians providing care through virtual or remote channels, because that's what must be done. We all have the desire to do our work well and to maintain the humanity in every encounter. Many of us, myself included, were taught, or we likely observed as our mentors modeled for us, how to hold someone's humanity tenderly and feel our way sensitively during face-to-face advanced care planning conversations. And now, we have no less desire or responsibility, really, to hold that humanity and maintain sensitivity. We just need to do it in a different way. And I think you will be surprised today at the possibilities for this different way and how wonderful it is. And today we're bringing you really the best of the best mentors that we know for the topic at hand. And with that, I want to introduce our presenters today. Dr. Michael Fratkin, father, husband, brother, son, and physician. Dr. Fratkin is dedicated to the well-being of his community. He's served his community in primary care in a community clinic system, as a medical director of the local hospice, as a leader in the community hospital medical staff, and a transformative voice for improving the experience of people facing the end of life. Dr. Fratkin created Resolution Care Network to ensure inspired, capable, and compassionate care for everyone everywhere as they face the challenges of serious illness. And he's a fun guy also. And Dr. Nathan Riley. Dr. Riley has the rare opportunity to care for patients through birth and death. He is an OBGYN and a palliative care and hospice physician. He lives in Louisville, Kentucky, where he works as an inpatient palliative care consultant for Norton Healthcare, as well as an inpatient and outpatient hospice physician for Hospice Health. He also serves patients for Resolution Care remotely, which is why he makes sense today. And of note, you should know that he eats his sandwiches crust side first. So with that, I'm going to hand it over to Dr. Fratkin and Dr. Riley.
Well, for goodness sakes, Dr. Riley, that's backwards. You should eat the crust last. It's the best part.
We're gonna debate this for years, Michael.
Right, but we're not gonna fill up the webinar time, are we? No. Well, today, I want to say thank you to Five Wishes. Thank you, Kathleen. Thank you, Paul, for 20 some odd years of excellence. The Five Wishes have been a part of my practice since I launched out of my residency in 1996. I live in far northern California, and I'm pleased to be co-presenting with Nathan. I'm kind of the old fart in the room, and he is the young buck, but together we both have a unique view of how technology will be a part of all of our future in healthcare provision, and how to get through and over some of the very understandable resistance that emerges in this rapid, kind of blisteringly rapid adoption of telehealth technology. So Nathan, what would you like to say, and hello to all of these nice people?
Well, thank you for that nice introduction. My name's Nathan. As Kathleen mentioned in the introduction, I'm still an OBGYN at heart, but I've moved on to palliative medicine as sort of my primary role professionally now, and so I get this unique experience where I get to actually help people go through two very, very challenging times in their life, which is for my female population, it's the process of being pregnant, oftentimes for the first time, and going through what is often very exciting but can be very scary on the birth end of things. But then I also get to take care of men and women and children who are facing the realities of mortality. And the Five Wishes sort of program is something that I've used for years as a means of trying to help people ascertain risk, but also to sort of let it be known what it is that's important to them. Because as we all know, it doesn't matter how long you do this, talking about some of these things can be very, very scary for the patients, but also for family members. So before we get started, we are going to start with a poll here. But before we get started, a very short anecdote about why I think that telehealth is so important, even in this sort of age of COVID where now we're all realizing it's somewhat of a necessity at times. When I was in medical school, my father had multiple myeloma, and which is a very painful bone marrow derived cancer, and he was under treatment for 5 years, and he passed away about halfway through medical school. But during that time, eventually he, this blue-collar, kind of rough and tough guy from Pittsburgh, he agreed to see palliative care. And my mother, who had to take all of her time off of work for a day to take him to the hospital, had to load him up, had to get his achy body into the car. She had to avoid all the potholes, driving extra slow, taking turns extra slowly and cautiously. And then she arrived at the medical campus and had to walk him by wheelchair roughly 2 blocks or so to get to the palliative care clinic. And in the meantime, he had a large bout of diarrhea in his wheelchair. He was mortified. By the time he even got to the clinic, he didn't want to talk about any of these things. He didn't want to talk about his symptoms. He, of course, needed his symptoms managed, but he couldn't do that. And or he didn't want to do that at the time. And if we only had some basic telehealth technologies in place, at the facility where he was getting his treatments, this could have all been avoided, right? And so telehealth is extremely important to me, Michael, and the opportunity to have worked with Resolution Care has allowed me the opportunity to actually implement some of these things from thousands of miles away in Louisville, Kentucky, for the patients that you live more in proximity to up in Northern California. So I think this is critical technology, and advanced care planning is really not one of those things that needs to be pushed to the wayside, especially when we have people that need it so badly. And sometimes the people that need it more than anybody are those who can't come in to see us in person.
Well, right. Well, so good. Enough about us. Let's find out about you.
Yeah.
I'm really interested in the results of this poll. So please do take a stand, click an A, B, C, or D, and we'll use this as a sort of next jumping off point. And as a I guess a teaser, what I hope to accomplish at the end of this encounter together is that you might understand that actually telemedicine is better than real life. You can see where I voted. Good. Well, I think we've got a pretty good showing here. There's a few more trickling in, but I see that what we're seeing is that most people are coming at this particular challenge and the use of these technologies, video conferencing technologies, in the C category as a suitable compromise only if necessary. And I think that's really pretty much what I expect. Is that what you expected, Nathan?
Yeah, absolutely. I mean, like I said, I think that it really, it really means more to be sitting with a person, especially in the way that we've learned how to practice. But hopefully, yes, I think that we have enough experience to actually convince our colleagues that this actually can be better. I think, and hopefully we can impress that upon you all through our presentations today.
Yeah, there we go. Well, let's go ahead and move through the polling question, and I'm going to tell you a little bit. There's the results. Oh, we have another polling question. There we go. Do you believe you can establish a meaningful connection and have compassionate, effective advanced care planning conversations remotely over virtual or telehealth channels? It's already working. They're already believing me.
The power of persuasion.
The power of suggestion and persuasion. I haven't had a chance to persuade, but I have suggested it. Well,
Sure have.
Do we have a polling question about people's crust sandwich behaviors? I don't think so.
We all know where the majority is going to lie there, Michael. You're always going to be on the fringe. So let's just leave that one for another day.
On the fringe. I am always on the fringe. But good, yeah, no, I think that what we're seeing, at least in the initial, is that people are showing up for this conversation and this webinar with the idea that, yeah, it's possible. I can imagine that it works, and there's just a smattering of folks that don't think it can work, and many people are appropriately sort of in the middle. Well, let me tell you a little bit about us, and this is a kind of an old, out-of-date slide, but I want to tell you a little bit about Resolution Care Network so you know what experience I'm calling forth to make this conversation. So Resolution Care Network is a home-based palliative care program that arose as a result of a crowdfunding campaign in 2015 by a somewhat serially burned out country doctor that was me. I built Resolution Care Network and launched it in 2015, and to date we have about 200 people under our care, about 35 employees. Some of them live in Louisville and others live elsewhere in the country, and work with a interdisciplinary or even transdisciplinary team around each person that we care for. So for those that are not as familiar with how palliative care works, palliative care is a specialty of medicine that uses a team to improve the quality of life for people and their families as they navigate and make their way through complex medical situations. It's an extra layer of support to primary care, oncology care, cardiology, and we work with this multi-vantage point team to understand better how to care for people. Like probably most of you, you are a choir. We care a lot more about what matters to them than what's the matter with them. So we built this program, and this is substantially out of date. That was probably a year ago. We could say that 20% of our people were utilizing telemedicine. We advanced that further, and until about two and a half months ago, or 2 months ago, we had about 45% of all of the care provided by nurses, social workers, chaplains, community health workers, and physicians. About 45% of everything we did by video conferencing. On about, I think, March 16th, we went from 40% to 100% overnight. And there's two things I want you to know about that. One is our patients, the people we care for, didn't really notice a difference. And number two, the bigger challenge has been our team that have experienced some losses for some of that personal intimacy that comes from being in the same place as the people you're communicating with and caring for. Although over the course of the last few weeks, people are adopting and creating this as the new normal, and also becoming kind of fascinated with the environment of care. So we're funded through value-based payment rather than fee-for-service. That changes the game. All of our patients, all of the people we care for, have high-quality advanced care planning discussions and documentation. And just FYI, our preference is to use the 5 Wishes documentation because of all the reasons that Paul outlined. It was born out of respect for human beings and their unique qualities, and the need to provide them dignity through asking them to enter a conversation where their wishes would be made clear at a very personal level, as well as at a legally rigorous level. So as we go along, you'll see some of the people we care for. And we take care of about 80% of our patients, or folks that we care for, are folks that depend on the safety net. So they're not folks that have a ton of technology at their fingertips, although that's changing over time. So I've used these photographs just to tell you, to share with you how I feel about the people that we care for, and I want you to feel it too, and see in their eyes all the sort of unique qualities of every individual. And so Nathan, tell me a little bit about, you became interested in what we were doing, and you began, doing telemedicine work. What were some of your initial impressions or barriers or challenges before you kind of discovered it worked?
I think that the biggest barrier for me was sort of my own kind of denial that this actually could work. Sort of like I need to be convinced that this is actually going to be representative of the type of interactions that I was able to have with patients in my fellowship, right? So I went from a very surgical field to a very kind of sit down, slow down, and be with people in that moment of their pain or their suffering or their fear or their joy. And I wasn't totally convinced right away that this could be done over the web. But then one thing that I learned very quickly was that there was a significant portion of my patients who, like my father, or and like many patients that many of you have cared for, who where dignity has kind of been drawn into question by their illness, right? So they may have ostomies, they may have a leaky nephrostomy tube, they may have a wound that just is malodorous. There's 1,000 different things that sort of complicate their care, in addition to the realities of what it means to be sick. And so what I came to realize was, okay, if I can connect with them by web, it lets them provide to me their sort of superficial presentation, right? They don't have to worry about the smell or the appearance of their wounds or the incision that isn't well healed on their face or whatever it is, because they can kind of show you the side of them that is most dignified, which allows them to be vulnerable with you and to sit with you. So I think that my own bias was kind of the main barrier. I think that's common. I think that's really common. Yeah. What I'll tell you is I'll tell a little. When you think about having to go to the doctor, number one, you end up if you're quite ill and you're going to the doctor for a palliative care purpose, well, you're going there to have improvement in your quality of life, but this is your experience. You have to get yourself ready. You have to get yourself dressed. You have to move your walker. Your daughter usually, or maybe somebody else, a friend or family member, has to take time off of work to get you in the car with your wheelchair in the trunk or however, through either hours of driving on country roads in our environment or through crazy traffic and parking problems. Then you get out of the car, you get into your wheelchair, you get rolled up into the clinic where they shove that clipboard in your face one more time, and you sit in a waiting room where people are coughing and don't look so good, and you wonder how you look, and you wonder what they're coughing, and that was scary even 3 months ago. And then you're burdened by the 10-Year-Old People magazine, and they take you into the back room, they put you in a room with no windows and some diagram of your sinuses on the wall, and you wait in this quiet space staring at the tongue depressors until the hurried and harried doctor comes in, and then sits down in that space, but then turns their attention to the computer and all of the physician or provider-centered metrics that they have to accomplish. And then just as they're leaving, you think of that last one thing that you want to talk about. It's not the greatest environment for these kinds of intimate conversations around advanced care planning and wishes. And then you reverse the whole thing, you do it again, and it may be your third, your fourth visit in a month, including laboratory tests and x-rays and all the things that come, right? And then instead of that, what they get once they're all enabled is a link and an email. They click on the link, and you click on the link, and there you are. They're sitting there quietly in their own room. Yeah? Mm-hmm. And yeah, go ahead. Oh, no, I'm just nodding along. You're just speaking. Oh, you're nodding. That was an audio nod. Good. An audible nod, and then an audible nod. That was good. And then it turns out that when you see them framed, literally framed in this space, they have their own autonomy. They show you whatever they want to show you about their home, and everything you see by consent. So you can ask them who else is in the room. You can work with them to enable and overcome their resistance to technology. And then you can, when you finish setting things up, setting the stage, being the director of this experience, you can embrace the opportunities and advantages of this new care environment. We take for granted when we see people in an exam room that environment has an impact on the experience. We take for granted that when we enter a person's home or invade their home, that has an impact
on the experience. We take for granted that a bedside discussion in the hospital has its own environmental context. Well, let's not take for granted this new technology and this new framed space as its own environment that's very interesting and unique. It preserves the autonomy of the person. They're in their comfortable space, and it also preserves a boundary between you and them. So I'll pause there, but this is part of my excitement for what works. And Nathan, do you have anything to ask? And then we'll turn to Kathleen for a few questions.
No, I think you summed that up pretty nicely.
Nice. Kathleen, do you have any stuff coming through the chat that we can start to respond to?
Yeah, we do. And actually, a lot of these are similar types of comments and questions that we're getting, which is nice. And I think it's really hitting on what you were talking about with the clinicians being the biggest challenge. And I think what I'm hearing in the comments and questions, it might be fair to recognize for a couple of minutes, and maybe you can both talk about how to address the grief that clinicians have in letting go, to some extent, of the in-person visit. I'm hearing people say there are some things you can do in person that you just can't do over the phone. You can notice, you can hand someone a tissue, you can touch someone, you can notice jaundice. You can't do that over virtual channels. So I think it's, what that sounds like to me is it's change.
Those two things that are, yeah, no, that's really good. Let's separate those two things, because one has to do with what you can see, experience, and objectively extract from the virtual space. That's like, what do you need in terms of physical exam and assessment and understanding the physical well-being or even the medical elements of what is happening over there. But then there's this other piece, which I think is actually a little more juicy and interesting and surprising to me, is that when we switched from 45% to 100% teleconference, and we got the people who were resistant, the patients that we were caring for who were resistant, to get it up and running, they were some of the most enthusiastic embracers of the new technology. They got it instantly, and they realized that they wished they had started doing it earlier. So the people we care for adapt to it and experience a great relief from a lot of those kind of extraneous stresses that are perhaps in the way, and maybe we're blind to them, they're invisible to us, but they're really clear about the gains and the benefits for them. But what has been most interesting is this sense of loss from the healthcare providers about their need to put an arm around a person, their need to draw up and hand a Kleenex to the person that they're engaging with. That has been more persistent and persnickety because our healthcare workers have their own set of needs that they didn't actually realize they were asking the people we care for to fulfill. Nathan, do you have anything to say about that?
Yeah. I actually was sort of thinking along the same lines as you, Michael. One thing that I think I learned in my surgical training was if a person becomes emotional, you need to run and get tissues, and you need to wrap them up. And I even do it. I even used to do it for my wife. Like, she's crying, so I smother her in my love. But what I found actually, and in person, that does sometimes need to happen, especially if there's snots coming out and they're just a big mess. If they're in their own place, then they have access to their own tissues. They're often accompanied, in my visits with patients, they're often accompanied by a loved one who otherwise maybe wouldn't be able to be there with them in the hospital, especially in the ages of COVID. They're actually accompanied by their spouse or their child or their granddaughter or whoever. But what's actually more interesting to me is that because my patients that I'm seeing by telehealth are actually in a space where they feel maybe that they can be safely vulnerable, I find more often than in the hospital or clinical setting, I actually find that we're looking at each other eyeballs to eyeballs, and we're kind of empathizing through one another, that there's an element of suffering here. And I've actually I've actually cried with patients through this telehealth lens because we both feel like we can be safe being human and just sitting with this suffering and sitting with one another's pain of being human. And the biggest source of pain, I think, is when we're challenged with this end of life issue. So I echo you in that we feel that because we can't provide that physical touch, that we are doing a disservice. But in some cases, I've actually been able to let them kind of go through that therapeutic process of crying and feeling through this really scary place that they are, more so through the telehealth lens.
Perfect. Yeah, no, that's exactly my experience. There are certain things that I used to do that I cannot do in this environment, this context, this frame. However, there are many things that I do much more intentionally within this frame that I can't really do because it's a simplified environment. It really is literally a square, a rectangle, a frame in which to interact with people that doesn't have all of the primate social behavior requirements. And in fact, it turns out that it's more efficient to continue to get from point A to point B with people and feel complete. It tends to happen in a shorter period of time. In regard to that other element of the question, like you can't see jaundice or you have limitations in what you can do with physical exam, if you were to send me an email at michael@resolutioncare.com, I'll share with you a resource list that I've just put together that outlines something. If I was to count them all up, I think the number would be something like 140 physical exam findings that you can reliably obtain either directly through observation, manipulations, moving the camera around, changing the lighting, or even more personally, engaging the caregiver or loved one to assist and be your hands on the ground. You can coach them in these sort of physical exam and kind of maneuvers that empowers and kind of professionalizes and honors them for their value at the bedside. So yeah, there's that.
Yeah, I agree.
What do you got, Kathleen? Do you agree with that? Yeah, good. You have to agree.
Yeah.
Except for the whole crust thing.
Here's an interesting point. I think we do have, so I know you guys are going to talk about some practical. We've got a lot of people saying, okay, how do you do it, though? I think there are people feeling lost about how do you even get there. And I know you had some things you were going to review about the setting and about physical cues and those kind of things. Can you talk about some of that?
For sure. Why don't you talk about your approach to setting the stage, Nathan, and then I'll riff from there.
Yeah, absolutely. Well, I think that actually one of the first things that actually gets into sort of the rapport building that we do with patients, but also symptom management and then my physical assessment, as well as even some challenging conversations, is that the telehealth, the one attribute that I love the most is that they can pick their little iPad up or their smartphone and walk outside and they can show me the space that they call home, right? This is where I feel safest and most comfortable. And in the process, oftentimes, I'll even ask patients, hey, if you feel comfortable, show me like your yard. They're so proud of the redwoods in the back. And by them actually getting to show me who they are, I also get to see them in natural light, which allows me to, I have diagnosed jaundice. I have said, hey, you look a little yellow to me today. And then I'll ask their partner, do you feel that same way too? So the first thing I usually will say is, can you just show me around? And they won't show you their pile of dirty laundry. They're going to show you this great macrame thing that they made because that's what brings them so much joy. So you get to learn a lot about a person just by getting them to walk around, and you get to see, can they walk around? So instead of restricting them to this crinkly paper on an exam table in an outpatient clinic, which, for some people that actually is necessary. But for many patients, I get to actually see them stand up and walk across the room to show me these tchotchkes that they've been collecting for years. And it's like, it brings them so much joy. So you get to see a sick person who has the blessing of being able to describe these things while also getting to, position themselves into natural light so I can do a physical exam. And then I'll also, and also just having them aim the camera at things. You know, like I've got this funny thing sticking out of my belly now, and you can see there's some sort of nodule or something there, right? Or their feet are swollen, and if you're paying attention, you can actually see that, ooh, those look a little bit more swollen than they did before, or those are weeping lesions on your feet. So I think that I think that answers your question, right?
Well, yeah, and that sort of answers the question, and I'm going to kind of focus up on a tactical set of tips for people related to setting the stage. My friend Brooke Colton, a palliative care physician and telemedicine leader, likes to talk about it as setting the stage or being the director. It's like being the director of a stage production or being the director of a movie set. What I do is at the beginning is I assume that both they and I'm dealing with a little bit of techno-anxiety. Adapting from my default world of walking around and touching things and everything else to a virtual world, a framed environment. And that is a big difference. And so there's a transition for me, kind of psychically or energetically or attention-wise, and there's similar, probably even more so for them. So when stepping into the space, I ask them, I acknowledge that we're doing something that's a little bit weird. I have them, for example, set the device, whatever the device is, away from their hands. If it's a phone, I have them prop it up, or an iPad, I have them prop it up so that they can free their hands. And then I check with them, are they hearing me okay? Can they see me okay? If they're backlit, if there's a bright light source, a window behind them, it silhouettes their face and eliminates a ton of the communication that's coming my way. And as it relates to advanced care planning specifically, getting all of that set, finding out, is there anybody off camera, for example? Is your sister, your brother off camera? I get all of that stuff handled, and then I acknowledge and confirm with them that it's handled, and then I begin. And I explicitly say, okay, we've got all that stuff handled. Now it's time to begin this important conversation. And just that simple little maneuver takes people from dealing with the context and the medium and the channel of communication and dropping right back down into the conversation itself. As it relates to advanced care planning, there's usually very little in the way of physical exam findings that I'm oriented towards. If it's a part of a broader palliative care evaluation and assessment, well, sure, it's in there. But actually, for what I've made a date to lean into understanding a person's view of their own illness and their set of preferences, and then that's a very, very much amenable. And I'll just say for each of you as operators, once you get going and doing this work, one thing that you'll realize that you never ever had before was a real-time mirror of your own presentation. I had talked to Kathleen and to Paul about the idea of doing this very encounter, this very webinar, using a Zoom interface so that I could see all of your faces and you could certainly see me. I'm pretending that you can see me. I'm looking at the camera. I'm using my hands up in the frame. I'm engaging with you as if you can see me. And maybe at some point we'll do one similarly via Zoom where you actually can see me and I can see you. And if you have a question, you don't have to type it into a chat box. You can just raise your hand.
This is, Michael, this is leading me to a question we've had a couple of people bring up in the chat box here. Can you speak to the difference in how the intimacy might change and how we can ensure that it also is there and developed in telephone encounters versus encounters where you have video and sound? We've got, I think, a lot of people that are starting with one and have not yet moved to the other. So can you talk about how to create as much intimacy as we can over the phone as well as video?
Yeah, Nathan can follow me, but the concept when we watch a television program or a movie on a screen is this concept of suspension of disbelief, right? The framework and technology disappears, and you are in a communication with a person within the opportunities and limitations of whatever that communication channel is, right? So if you're passively receiving a television show or a movie, you forget that you're watching a movie, mostly, if it's a good movie anyways. The better the movie is, the more you become engaged with it. But you're sitting there passively receiving it. When you do a telephone call, in that synchronous audio-only encounter, there are opportunities and limitations. There's something a bit more reflective sometimes about telephone, and certainly people completely are oblivious to the fact that they're using a telephone once they're involved in it. Although some people are good at it and some people are not as good at it. And these are delicate conversations. As you expand the amount of information moving, literally in terms of data and in terms of just the amount of human communication happening, the video itself provides such a depth, it's like an order of magnitude more and better communication. And so from telephone, you can do a lot. We've got a lot of experience using telephone to have meaningful and purposeful communications, for sure. With video, adding video to it, I would challenge and dare people to be brave enough to ask people if they're making a telephone call, hey, are you calling me on an iPhone? Because it's as simple as changing that communication to FaceTime. Or when you're setting up these appointments, though you certainly can be reimbursed for advanced care planning discussions by telephone for a minute during the federal designated emergency, I would challenge people to use video conferencing when they can. And in the current environment, you are able to use essentially any platform. The easiest one that's at the fingertips, if you happen to have people that are both on Apple devices, FaceTime is adequately and acceptably secure for these communications, at least during this moment. I see that Letice Moore asked if it's HIPAA compliant, and so I'll unpack a little something about the current COVID environment. In the current COVID environment, the Office of Civil Rights has said we will not be auditing or dinging anybody for the use of any video platform of any sort during the period of the federal emergency. Prior to COVID-19, a number of large organizations had determined with their 333 lawyers that FaceTime is adequately secure and adequately HIPAA compliant. Other large organizations and groups of other 342 lawyers say it's not. I can't really say, but there's never been a case where somebody using FaceTime for a clinical encounter has been dinged for HIPAA. That probably changes after COVID-19. Zoom Professional is entirely HIPAA compliant without any concerns either before, during, or after the COVID-19 emergency. But currently, you can try using anything. Skype, Facebook Messenger has a video function that a lot of people who've never done it before can be easily accessed with a click of a button. So I think that answers some of those things. One of the questions I noticed as it went scrolling by was, what do you think that video conferencing and telemedicine is here to stay post-COVID? And while I can't, the only thing I know for sure about the future is that it hasn't happened yet. My conversations with thought leaders in advocacy, policy, and regulation is that quite likely after the federal emergency, video conferencing as equivalent to office visits or hospital visits will persist and be durable, whereas telephone probably will not be, because there really is quite a difference in the quality. In the here and now, while we're dealing with COVID, it makes perfectly good sense, and I'm appreciative of the regulators to allow for telephone to be used quickly and responsively inside of COVID. But I think that will probably go away. But video conferencing as a mechanism for doing advanced care planning and video conferencing for doing clinical work will not go away. That's my reading of the tea leaves.
Thanks for that.
Michael, could I add on to that?
Yeah, go ahead, Nathan.
I echo everything you said, and I do think it is here to stay. I think that most of the big hospital systems as well, including the one that I work for, primarily in Northern Healthcare in Louisville, Kentucky, are sort of realizing that, oh my gosh, not only is this possible, but patients are actually highly satisfied with video conferencing. Having said that, the majority of phone calls that I'm making from a hospital setting, and to many of our patients that we're seeing remotely through Resolution Care, who don't have access to video conferencing, those phone calls, you're still using the same principles that you use, and you have to constantly remind yourself of those same things, to slow down your speech, to use little mm-hms and those audible nods that you hear Michael and I doing to one another, to just let the other person know that I'm listening, I'm here, I'm engaged. And most importantly, to pause and to really allow pauses after you've asked those heavy questions, and to not fill it with more medical information. I know that this sounds like common sense, but that's the only thing that really matters when you're having these big conversations, is to allow the person to sit with these questions and to really explore them. And you, by filling that void with more language, you aren't necessarily speeding the conversation along. You may just be allowing us to sort of subvert around the challenging points. That's
particularly important in telephone work, or in this audio-only connection between you and I say,
exactly.
And then I also send you these other kinds of audio messages that I'm gonna step on the last thing that you said, because I got something I want to say. Right? So in telephone or in audio-only encounters, you've got to do that by audio, and it sends kind of conflicted messages, because I respect Nathan. I don't want to step on what he's saying. On the other hand, I want to be responsible for the whole flow of the encounter. So what he said about pausing and giving good space is extra important on the telephone. I've noticed a couple of questions come back, like, what do you do when the technology gets wonky? Like if it's glitchy, or if they freeze, or all the rest. How do you handle that kind of interference and noise in these encounters, Nathan?
Sometimes I'll just have them call me back. Like sometimes I'll say, you know what, let's get off the call, let's reconnect. Sometimes it may be a matter of just having them go to a different corner of the house where they know they get a better signal. And then other times, I've visualized you, just aim the camera down. I can't hear you, but just aim the camera down for me. Let me see your ankles. Let me see the new flowers you planted out front. And then why don't we get off of this because we're laggy, and let's just get on a regular phone call after that. They at least see that I'm there with my hair done and my shirt buttoned up, and I'm there with them on the other end. There's a real person there. And then when we go to phone call, Michael, I think it ends up being a little bit easier for them to engage by phone. I'm sure that's your experience too.
It is. I think the principle that I want to get across to people is don't freak out.
That's right.
The more calm,
first and foremost.
Be calm, relax, problem solve as able, and then pivot and adjust as needed. The people that we're seeing are so vulnerable and so ready to be anxious that the best gift you can give them is to stay grounded, stay lighthearted, and adapt and lead the conversation. Stay in the director's role, and be willing to, change the approach or change even the technology that's being used. So stay calm when things get glitchy.
And I think that's, let me ask you one more question that we'd be remiss without covering specifically today. And if we can do it in a minute, that would be great.
We can.
With regard specifically to advanced care planning conversations, what should we be focusing on in the middle of COVID-19, given that a lot of people are interested in advanced care planning because of COVID-19, and it's changing a little bit of what we ought to focus on because of the context. So can you talk to us a little bit about what we should be thinking about and addressing in these advanced care planning conversations?
Yeah, please, Nathan, why don't you tell in 1 minute our little project and what its high-level principles are.
Yeah, thank you. Well, so this is a special project that we were working on with a young woman who has a small business called the Healthcare Cube, where she actually produces videos that are meant to alleviate some of the pressure on physicians and other providers to having some of these, quote, routine conversations with their patients. And so what we were finding is, while we're very good at having advanced care planning conversations, what we were finding is we were kind of reiterating a lot of the same materials. So what we actually did to facilitate more condensed, more pithy conversations about the nuances of who people are and what their values are, we produced a little video, which I believe is available on the website. Is that right, Michael?
Yeah. In fact, we'll pass it to Kathleen, who can send it out to the crew as well.
Yeah. Yeah, and you know,
the problem is that COVID-19 is a very special circumstance. It's not built into the conversations that we had generally about advanced care planning and preferences and wishes that people have. So we made a little video that lasts about 6 minutes that precedes an encounter, and we found that actually helps target the conversation to the specific nuances of COVID-19 and how that may or may not impact the directives that people have. Hey, let's do this. Let's give Kathleen a chance in the last 3 minutes, oh my goodness, to wrap this up. It's been a pleasure.
Oh, it's been a pleasure for everyone listening to you. Just with regard to that last question and advanced care planning, one of the things that I've been talking with a lot of people about is the importance of covering in advanced care planning conversations. And yes, it would be very specific to the individual, but we do need to talk about decision makers right now. I think especially when people are actually dealing with a sudden illness, that's something we do want to make sure we cover. And I think this pandemic has given us an opportunity to really explore with people how they feel about if that specifically is something that happens to me, what I might want. There was an interesting article that came out recently about a woman who has advanced cancer, but in updating her advanced directives, she said, if I contract this coronavirus, I want to be put on a respirator. If I'm diagnosed with my cancer, I don't. But if it's the coronavirus, try to get me out of that. So I think it gives us the opportunity to really kind of explore with people what they value and what these decisions mean to them. And we've got one more chance for you to see where you fall with this question. And the way you answer is just click on your screen. Actually, go to that button right by yes or no or I don't know and click on your screen, which it looks like you're already doing. And I'm delighted to see we've got most of everybody with a yes now about believing in this connection. So thanks for participating in that.
You know, that was really the intention. Like I'm noticing too, there's a number of people who've said, you know, I like to have more technical, prepared, kind of formal materials, and I think we can do that too. But I think that given how much change everybody's going through right now, my intention was to support people to believe that you can establish a meaningful connection using these technologies. And so I feel pretty
And I think
successful,
mission accomplished with that,
Mission accomplished on that, but I also think that there are some technical materials that I can provide to you that you can send out to folks that have a little bit more practical, formal stuff that will help them put one foot in front of the other and get rolling.
And one thing that we can do, if I can go to the next slide, please, is pair what you're talking about. Can we go? There we go. Just so everyone remembers, I know all of you are using perhaps different components of the 5 Wishes program, but the 5 Wishes online training modules cover a lot. Now, while it may not be necessarily specific to virtual advanced care planning, the same principles apply about presence and developing empathy and conveying those regardless of how you're interacting with the patient and the family. So check out the online training modules. They are quick, they're an hour long, they're accessible, they're inexpensive, they go very well with the rest of the 5 Wishes program. And then we've got our conversation guides for clinicians, which are great for kind of a just-in-time guide to what you ought to be covering in the conversation. It's really, you know, the 5 Wishes are 5 domains of what to cover in a conversation or through a series of conversations as the patient and family are comfortable. And if we can go to the next slide, please. We also have our patient education materials. And I think one of the things that Dr. Riley mentioned is that your advanced directive is a patient education tool. It is. No matter which one you're using, it's educating people. So think about that carefully. And the 5 Wishes Advanced Directive document is a wonderful patient education tool because it has so much soft and ease into the conversation. So it's an education tool, and we also have a companion conversation guide for individuals and families that even if you can't be present, I think people can do pretty well with these materials paired on their own if they have to, and we hope you will be with them. But I think these 2 things paired are a great resource for either virtual, telephonic, and or in-person conversations. So keep those in mind. And the last slide, please. Just remember to give us your feedback and contact us. Let us know how you are using the program and what else might be helpful to you, where your challenges are. That's what we've been doing, is developing what you're telling us you want and need so that you can have the most compassionate and most effective conversations with the people that you serve. And thank you for serving them. Thank you. And thank you for joining us today. And thank you to Dr. Fratkin and Dr. Riley for this today. Thank you.
Our pleasure. Thank you.
It was a pleasure.
Truly.
Thank you, Kathleen. We did record the session, and we will have the archive available within 7 business days. You may access the recorded archive by visiting the 5 Wishes Practice Community page at 5wishes.org/practice. Look under Webinars. Feel free to share the page and webinar link with your colleagues. On behalf of the 5 Wishes, thank you to our speakers, and of course everyone for joining. Have a wonderful day, and you may now disconnect.